And I'm really excited to be here, especially excited to be here in person. Nice to see real people in 3 dimensions. And now we have a new way to describe ourselves as economics, which sounds a little more exciting because health economists are generally thought of as fairly, maybe not so exciting people, I must say. So now we have a new omics. I know it'll be good. So I would also take on that and say I'd almost like to position this session as patient or person omics a little bit. So I'll leave that thought with you that just occurred to me as I was sitting there listening. But what I'm going to do is talk about a couple little things to expand on my colleague's introduction here to beyond cost effectiveness and think about value. How do we think about value in precision medicine? So I'm specifically going to talk about non-health benefits and something called preferences, which we'll talk about a little bit later. So these are going to be my 2 main focuses, and I'll talk first of all about measuring what matters in terms of patients, so bringing in this perspective to reflect value in personalized medicine, and I'll talk a wee bit about productivity costs and losses and spillover effects and non-health outcomes. And the second point around methods. So there's a couple methods we have in health economics that we can use to help try to measure this value, and one of them is patient preferences, and we can think there about personal utility, willingness to pay, uptake of treatments, and benefit risk trade-offs. And the second one I'll mention is simulation modeling. So, we talk about these complex pathways that have come up many times in this discussion, and you're all very familiar with. Thinking about the simulation modeling methods to capture these trajectories and these downstream consequences. So, although there's many types of cost effectiveness and lots of details per se, I'm going to represent this in what I call my martini glass with 3 little olives. I'm glad it's the afternoon and we didn't get the morning session, but effectiveness and costs, and then we combine that into a ratio called the cost effectiveness ratio. And this is the typical approach that's used. So we look at effectiveness. Typically, life years are used. You've certainly probably heard of the QALY, our friend the QALY, the Quality Adjusted Life Year, which is very contentious amongst my colleagues. And then secondly, we look at costs, monetary expenditures, whether it's in euros or dollars or yen, that are associated with typically direct costs of health services, and this is a key point that I want to point out. And then the last piece is bringing it all together in this incremental measure that we call the ICER, the incremental cost effectiveness ratio. So that's your typical approach, precision medicine versus standard of care. So what I want to just point out to you, and this is just an example, but it's a systematic review that I think illustrates the point. And the point here is essentially that we typically focus on these direct costs. And there's nothing in and of itself wrong with that per se, except it's only one aspect. And particularly when we're dealing with rare diseases, which a lot of diseases affected by precision medicine or personalized medicine are, this makes a huge difference. So you'll see here that only 7 of the 49 studies included in this systematic review, this is in rare disease as an example, essentially are on medicines, hospitalizations, outpatient business visits, all of those kinds of costs, but don't include these other kinds of productivity costs, transportation, informal care, and these kinds of things that, as you know, really can make a huge difference from the patient perspective. And there's some things that are unique to precision medicine, things like getting advanced genetic testing where this is covered, getting access to private labs and payment. Participation in research actually was raised in our Delphi panel as something that's important. And the time that the physician spends advocating to get the tests and the treatments that are needed for their patients. So what I want to do is, I'll come back to this, but those costs, I forgot I meant to mention this, are often equal or even larger. The non-medical direct health costs are often larger than the medical costs in cases like rare diseases. I'll come back to this later. I wanted to highlight the fact that we are more and more starting to think about what we call extended cost effectiveness. So broadening our viewpoint on cost effectiveness beyond those direct medical costs. And in particular, this is at the International Society for Pharmacoeconomics. This is a framework that was developed recently and gotten a fair bit of attention. But I wanted to draw attention to two points that I'm going to talk about. One is the work productivity aspect, and the other is what we call spillover effects. So how does this affect caregivers and family members? And I will mention here also that in the context of most economic evaluation guidelines, and certainly in our Canadian context as well as others, the standard reference case for doing economic evaluation is to focus on those direct medical costs. Okay. Now they do mention and acknowledge that we could take a broader view, but that's not considered the reference case in economic evaluation. So just flipping now to the specifics around assessing value in precision medicine, you can think how these particular points, these idea about productivity, spillover, thinking about the patient preferences, et cetera, are particularly relevant. It's not that it's not relevant in other aspects, but in precision medicine, we have testing, treatment that has to be coupled together, right? We have multiple actionable results and also non-actionable results that could come out of this. And it has potential downstream implications for both patients and their families. So I would just emphasize that in precision medicine, I think this is really an area where it matters to a very large degree. And precision medicine, therefore, has these non-health, health, and what we call process outcomes. And my message to you, if nothing else comes through, is if we don't measure these things in precision medicine and we don't account for them, we won't be able to bring the evidence that we need to bear to the decision-making that we need to make. So there are a lot of hidden consequences of precision medicine around testing and treatment. We have, this is the classic iceberg where you see the direct healthcare costs typically in reports and economic evaluations, but there's a lot underneath the water that we can't see. So things that we think about as sort of hidden consequences. And there's a whole list there, but as I said, I'm going to focus on a subset of this for this presentation given the limited time. So now I'll use this example. I'm going to focus on a couple of examples from our Genome Canada and Canadian Institute of Health Research precision health programs that are funded. And the first is in rare disease. So I'll use that as an example. And I'm also going to use our childhood arthritis example as I go through these. And to start with, just in general, I had mentioned this earlier, but these productivity costs that I referred to can actually equal or exceed direct medical costs in rare disease. And this was an unusual piece of evidence that came forward, done in the US, admittedly. It was using claims data and also using surveys from 379 different types of rare diseases. There's over 1,000 patients with rare diseases. And what you can see from this, the key message is simply that over on the left, we have the red, which is the direct costs. And the yellow-orange in the middle are these productivity costs. Well, you'll see that they're equal or more than what the direct costs are. And there in the purple bit is also these non-insured sort of additional costs. But it's a big piece of what the burden is overall on families, mostly borne by families and the patients. So I think this is an important aspect. Now, using one of those examples I mentioned, this is from our Understanding Childhood Arthritis Network, Genome Canada funded grant. This is productivity lost. It's looking at children with arthritis, which you might not typically think about in precision or personalized medicine. And I'll have another example later, but this is work productivity. So let's just think about this. So overall, 12% of parents in our data had to change their work commitment because of their child with juvenile idiopathic arthritis. Now, I know this doesn't surprise anybody here, but I think we have to document these things and bring the numbers to bear so that we can account for this. So 73% of parents reduced their work hours because of this, and 13% had to stop their work. Those are pretty big numbers. Then with the work productivity questionnaire, you can also look at absenteeism, so being away from work, and presenteeism, where your productivity is lowered. And you can see the numbers there, 3.2 hours of work a week and 26%, I think, of presenteeism. When you combine that, the overall impairment is 26%, so a quarter impact on people's productivity. And then in addition to that, we can also look at usual activities, and there was impairment of 20% on average in these families. I would say that's large. Secondly, spillover effects. So spillover effects are these consequences on health-related quality of life, which is HRQOL on the slide, to caregivers and family members. These are rarely considered in cost effectiveness. And again, there are lots of other studies, but I pick out this one because it's a systematic review that's recent. So in these 80 studies, only 8% actually reported any of these kinds of spillover effects. So we're not measuring these things. And most of the studies didn't actually have a comparator, which all of you know as scientists is really important, so that we can understand it. And we're now starting in our national bodies to say, gee, maybe we should think about these spillover effects, but it's not the standard case. This is an example, again, from our Understanding Childhood Arthritis study. And now I'm looking at the caregiver quality of life in parents. And yes, you can see that there are, at the top, there are positive things about looking after a child with arthritis. There's fulfillment effects, okay? But 38%, 39%, 34%, so about a third of this sample report having no support for their caregiving tasks. So obviously this is a burden. And about a third, again, report some or a lot of problems with their physical and mental health. So there is this burden, and I hate to use that word, but I'm afraid that is how it is referred to in the literature. There is an impact on the caregiving quality of life for parents. So now I'm going to change up the olives in my martini glass and say, let's add an olive here. Yes, I'm going to keep my costs and I'm going to keep my effectiveness, but I want to add in my personal utility and preferences. So here what I mean is that we want to go beyond the traditional metrics we use in cost effectiveness so that we can try to support decision making that's a bit more broad. And here I will say we want to look at personal utility and preferences. So now thinking about the non-health value that's associated with process outcomes, and features of a treatment or a management process. And so when I use the word preferences, I'm not using it in a lay kind of language way. I'm using this in the context of very specific methods where we look at trade-offs and people make choices, and it's utility-based. In fact, based on Nobel Prize work on utility theory by Daniel Kahneman many years ago. But it allows us to look at how people make choices and what they value. And we look at both the desirability, the positive features that are attractive to us, and also the acceptability, i.e. the negative features that reflect harms, so we may not want to accept. And in this paper, we're looking specifically at next generation sequencing, but what this does is highlight to us the different preference-based approaches to valuation of precision medicine. And on the left-hand side is the traditional approach, so doing cost-effectiveness type of analysis. And on the right-hand side, in the red box there, what it does is say, gee, let's look at a few other kinds of things and ways to value the benefits of precision medicine. And we're looking here at things like doing willingness to pay studies. We can use something called contingent valuation, and we can also use something called discrete choice experiments, which is a specific type of preference methodology. And we can get at measures like willingness to pay, uptake, because uptake is very important in any treatment pathway, and also utility that's outside of the usual type of value, and allows us to look at things like the value of information that's associated with testing results. So why do we want to look at preferences? Well, in short, and this is about 10 or 15 years of research work, because it matters to patients. And I see the lady who asked the question earlier asking about the patient choices. Yes, and if we think about what matters to patients, I would posit to you that we can improve the adoption, the satisfaction with and adherence to clinical treatments. In rheumatology in particular, and I know in all the other diseases I'm sure you work in, we have about 50% compliance rates to very expensive biologic treatments. I see that as a problem because it's a waste, right? If people aren't taking their treatments, they don't work. So we have to think about why and tailor our treatments. So in my definition of precision medicine, I include preferences, which is the choices that patients make. So let me give you and finish with these very short examples of how we can use these methods to look at these concepts of starting with value of information of testing results. So here we've used a technique called contingent valuation. Obviously, I'm not going to explain all of that in this short presentation, but it's a method that we can apply, that's a health economic method, to try and get a sense of what is the value of information. So this happens to be in whole genome sequencing, and as all of you are very aware, one of the challenges is that, well, we call it a joint production problem. And what we have are a lot of positive outcomes and a lot of negative outcomes or implications that could come from incidental findings, for example, and implications not only for the patient, but also for their families. So there's this sort of multiple members issue. So when we did this survey, so contingent valuation is a survey technique where we're asking people what would they be willing to pay for this intervention. We looked at actionable findings in a gene report and non-actionable findings. And I won't go over the details here, but what we find is that some respondents perceive genetic information could negatively impact them. So you see that they are willing to pay nothing, or in some instances negatively pay. And what we observe is that there's heterogeneity in preferences. And I would suggest for you that, there's sometimes positive values for some people and sometimes negative values or negative utility for people. And we should be thinking about this when we're making choices around what we're reporting in our whole genome sequence test reports, because they value testing differently. Another example is personal utility I had mentioned, and I had mentioned these discrete choice experiment methods. And in discrete choice experiment methods, we describe profiles of alternatives, and then we ask people to choose. And then we've experimentally designed those choices, and we can infer how much they weigh, essentially, each of those features. In context, of course. So here we were looking at whole exome sequencing, rare diseases. So this is our SOLVE project, which is another Genome Canada research project. And we looked at their preferences. So I know this is a little hard to read, but the first group of attributes that describe whole exome sequencing are how do you get it? And they have preference for whole exome sequencing over other diagnostic tests. Not surprisingly, but it's kind of interesting because they value whole exome sequencing. And then the other attributes that are shown here are time to get a diagnosis, and the other things are positive impacts, things like being able to access social programs because of the test results once you get a diagnosis. And then there's negative impacts where your child might be labeled or bullied or seen differently, etc. And not surprisingly, patients valued positive impacts more than negative impacts. And then lastly, we also find that sheer increased knowledge about what is wrong with their child is valued independently from everything else. There is a value associated with that. And the other thing is changes in management. How do I manage my child because now I know they have a diagnosis? And similarly, access to the services now that they have a diagnosis. So, and then the final thing we were able to discern from that study, we surveyed over 319 families. Parents were willing to pay about 6,500 or let's say 3,500 euros. This is in Canadian dollars. I'm sure you don't know the conversion rates. It was about 3,500 euros to have exome sequencing or genetic tests. Then a final example, I think this is my final example, is about benefit-risk trade-offs in chemotherapy treatment decisions. Thankfully, one of our colleagues, Dr. Pullman, explained everything about breast cancer, so I don't need to, which is a good thing because I'm not a clinician. But what this was a study looking at gene expression profiling and the information it generated. It was a discrete choice experiment and looking at side effects, both permanent and short-term, and then looking at the physician's assessment of risk and looking at the gene expression profiling assessment of risk. And people were asked to trade this off. Obviously, I haven't explained all the details of the study, but a key result, and I wanted to show this because it affects their stated uptake of chemotherapy treatment. So these are breast cancer patients who have had surgery, who are now in a decision point of whether or not they should get chemotherapy, okay? And what we're showing here is that having a gene expression test score influences the probability that they will get chemotherapy. So that might not be surprising to you, but we can actually quantitate that, and this is what this graph is showing, that we can increase their uptake of this information based on the gene expression profile. And it varies depending on what the physician estimated their risk was. So this is a very interesting relationship that in a dialogue or in shared decision-making with patients can be influential around whether they get treatment or not. Now, the last thing is simulation modeling, which, as I said, is another method. Precision medicine is all about complex clinical pathways, longitudinal trajectories, and testing and treatment. So it's ideally suited to what we call simulation modeling. This is a checklist basically that are criteria or aspects that make simulation modeling useful and relevant in personalized medicine. And basically what this is telling us is that in precision medicine, this kind of modeling, because it's at the individual level and it requires individual patient data, we can stratify and embed decisions into the long-term complex clinical pathways to measure the value over time and consider all the testing, treatment, switching, starting, stopping type decisions. So I think, again, I propose this to you as a really important method that can be helpful in precision medicine. And I'll just illustrate that with our childhood arthritis. So we have a cohort of juvenile idiopathic arthritis. We can create a prediction model. There's been a lot of discussions about predictive models. We can use that then to identify who should be treated. So in childhood arthritis, there's IL-1, interleukin-1, which is a very useful, promising, hasn't been totally proven yet, but there's promising data about being able to predict and choose and select the right biologic for patients for treatment. Right now, the standard of care is trial and error. We have a whole list of biologics, which is great, except we don't know which one the child will respond to. So with these predictive algorithms, we can choose which one, if they need a biologic or not, and potentially think about when and if to taper these children. So finally, I think we can do more in measuring value in personalized medicine. I think part of it, a key component, is measuring what matters to patients and capturing those data. So we have the family and patient perspective, and we can evaluate these complex clinical pathways using these methodologies. So thank you so much, and I'm really looking forward to the conversation. So,
thank you.